The next part of the lecture tonight, we're moving away from regenerative medicine. So the first part, we're talking about, well, what things can we do to avoid surgery? Now I'm going to talk to you a little bit about, well, what if we can't avoid surgery? What can we do for you to really help move forward with treating your anatomy and stabilizing your spine? The different parts of the spine, the cervical spine, the thoracic spine, the lumbar spine, and the sacrum coccyx. You'll see there are typically 7 vertebrae in the cervical spine, 12 in the thoracic, and 5 in the lumbar spine. Most of the time, the degeneration that we treat on a daily basis is either going to be in the cervical or the lumbar spine. Those are the mobile segments of the spine. And they typically are the most common to degenerate. A lot of people think that those areas are typically injured by improper lifting. Most of the time that's not the case. Most of the time it's repetitive injury over multiple events that leads to just progressive degeneration of the spine. The spine wears out. We're mechanical. Our bodies are mechanical. So eventually we're going to have problems. You live long enough, you're going to have some issues with your spine. One of the most common issues that we see is called spinal stenosis, and that term basically means crowding of the spinal nerves, narrowing around the nerves. The nerves are pinched. If the nerves are pinched, you obviously start getting some symptoms, pain. You may get some numbness, you may get some tingling, you may get some general weakness that you may perceive in the muscles that are innervated by those nerves. In the picture that you're seeing, that's basically compression of the spinal cord in the cervical spine, in your neck. Now, when I see someone that has spinal stenosis, they're telling me that they have some type of burning pain, stabbing, throbbing pain. It's very unenjoyable for them when they come in to see me. Most people obviously don't want to see a spine surgeon. They're worried they're going to have surgery. Obviously, that's the last thing we're thinking about in most situations. I think 95% of people that see us don't end up having spine surgery in general. And one of our mainstays of treatment is exercises, meaning that we're doing types of physical therapy to try to open up those spaces around the nerves. We may use medications such as oral steroids. Sometimes we'll perform epidurals. The epidurals can help to open up those spaces around the nerves as well and prevent surgery. But if surgery is needed to free the nerves, we'll perform a procedure called a laminotomy or a laminectomy. And that's basically where we're removing a small portion of the bone to gain access to the nerve and then to free the nerve where it's no longer compressed. Studies have shown that patients have better outcome after surgical decompression than they do without surgery in the long term. The picture you're about to see is a picture of a laminectomy. So what that is where we've removed the posterior elements of the spine to release that crowding on the nerves. Right here, the yellow represents the nerves. And you can see that space has been opened up to completely free the nervous system so it's not pressed anymore. A lot of times this procedure is accompanied by a stabilization procedure where we may place bone graft or small screws around the spine to make it solid, to help protect it. Now, one of the big things that we do here to try to prevent you from having to have those surgeries like we discussed are epidurals. There are several different types of epidurals. The typical epidural that we did years ago was called an interlaminar epidural. That's where we place medication through the posterior elements of the spine, and we're injecting them directly on to the posterior part around the nerves. A caudal epidural is where we're placing the medicine through your tailbone, and a transforaminal epidural is a very focused epidural where it's placed along one nerve root. Most of the time it's given unilaterally, left or right. You may come in saying, I have left leg pain, right leg pain. We're placing that medicine very specifically on the nerves that are pinched to try to decompress them. This is an example of a transforaminal epidural. When you see this next picture, you'll see the dye that travels along the nerve we're trying to isolate that nerve, and then after we've isolated the nerve, we'll put a very strong steroid medication around the nerve and onto the disc to try to help with your pain, but also relieve some of the symptoms. So you'll see that in the picture. The next picture basically represents the different types of epidurals. Again, you can see where one injection is a little bit away from the nerve and one injection is directly on top of the nerve. So they can be used in different circumstances. A lot of patients will come in and say, well, I've had 7 epidurals, none of them have helped. And then we perform a different type of epidural for them, and it works extremely well. So a lot of times it's simply finding the right type of injection to work with your problem. One big issue that we see for patients that ultimately does lead to surgery is a spondylolisthesis. Some people just call that a slip. So what that is, that's the forward slippage of one vertebrae on the other. And you'll see a picture here in a second of what that is going to represent. Once that happens, the nerves get significantly compressed. Again, remembering that compression of the nerve is called spinal stenosis. So as soon as the nerves are compressed, you'll start having back pain, you'll start having, let's say, leg pain, you'll start having numbness or tingling down the leg. You'll obviously have disability. So if you look at this picture, you'll see that the L4 vertebrae has slipped forward on the L5 vertebrae. They're no longer in alignment at all. If you look at the vertebrae above L4, at L3 and L2, they're in perfect alignment. They're not coming out of position. That typically has to be repaired surgically. If you'll look at the space between the L4 and L5 bone, what we call the disc, you'll see how narrow that disc is between L4 and L5. And that's part of what causes it. The cushion between the bones has worn out. It's degenerated to the point where there's no longer any stability between the segments. Typical treatment, I'll still try to treat you conservatively for this. Even though we see this picture and we may think it's ultimately going to require surgery, we'll still try activity modifications, physical therapy, anti-inflammatories, we'll try spinal epidurals, we'll work with our pain management doctor, we do types of ablations or stimulators. There are a lot of things that we'll do. Ultimately, if we see all those fail, and either your pain becomes intractable or the nerve-related issues become too significant, including weakness in your legs, we'll move forward with a stabilization procedure. Again, that's what we talked about, where sometimes we have to go in and place these small screws and bone graft around your spine to realign the spine and to get it to become solid again. Nowadays, that can be done in a much less invasive fashion than it used to be performed. The procedures that at one point may have taken 4 or 5 hours and involved a 5-inch incision now can be done in an hour and a half to 2 hours and involve a 2-inch incision. Those procedures that may have involved a 4 to 5 day hospital stay now can be done even as an outpatient procedure. You'll see this little device in between the bones that's utilized to lift the bones back apart and to stabilize them. That's called an interbody fusion spacer. We can place those nowadays through very minimal access. The next picture you'll see is how sometimes we'll do the procedures through just small punctures on the back of the skin to be able to place any type of screws or these little spacers through those devices, rather than having to perform a large open surgical procedure on you. Now, the next picture you're going to see, this is an example of a lumbar fusion. So it's a spinal fusion that was performed many years ago. We used to simply place bone graft between the bones, and we'd put the instruments in to stabilize the spine. And that could be a fairly debilitating surgical procedure, the way we had to expose the muscle around the spine. Like we're talking about today, we're performing more minimally invasive, or what we like to term less exposure spinal surgery. What that means for you is less blood loss, less surgical time, less need for hospital stay in general, a quicker recovery, and typically the stability you get with some of the newer instrumentation is actually stronger than some of the older instrumentation that we used to perform. Most of these procedures that I'm doing nowadays, 1 and 2 level procedures, are outpatient procedures, meaning that they go home the exact same day of the surgery, or they go home early the next morning after the procedure. They may stay overnight if you have some type of other medical comorbidities that we want to watch. If you're a diabetic, let's say, or if you have high blood pressure, or if you have a history of heart disease, we're typically going to keep you overnight and watch you to make sure that you don't have any complications, not related to the surgery, but related to the anesthesia that you have to have in order to move forward with the surgery. The next procedures that we're looking at are the cervical spine. A lot of those procedures also can be done in a way now that's less invasive to you surgically, and the way we stabilize the spine is less prone to failure over time, because we're utilizing types of spacers that go in between the bones that really can't collapse. If you just place a simple bone graft in between the bones, that bone graft can collapse down. But these type of spacers that you see in this picture, they're made of a material that cannot break, cannot collapse. So once they are placed to hold the bones apart, that's more of a permanent solution. The newer spaces that we're using have a chemical that's been placed throughout them. It's called Hydroxyapatite. That's a natural occurring compound that's found in human bone. It enhances the speed of bone ingrowth. So once we place that inside these little spacers, the bone potentially grows faster, it grows stronger, you heal quicker. You know, that's the end result for you. Everyone wants to have their surgery. They want to heal up as fast as they possibly can and get back to life, get back to their normal activities. This little device that I'm showing you here, this is called a P-lift cage. I use this very commonly for my lumbar fusion procedures. One caveat, I did develop this myself in association with a company from Boston, and it allows us to make a very, very small opening into the disc space. It's placed into that disc space and it's rotated to lift the disc space up and correct any deformity. And we're able to do that with an extreme minimally invasive access. So, and we've probably inserted 300 or 400 of these devices without any complications whatsoever. So it's made a huge difference in how minimally invasive I can be with some of these surgical procedures, and how severe of pathology that we can treat. Before, we may not have been able to get access into some of these areas just because the problem was so severe. But with this, a lot of times we can do it. Another big change that we've made is this midline cortical pedicle screw. So the next picture you're going to see shows the difference in the screw alignment that we place. Whenever we place the screws from the midline, you'll see that the screws are closer to the center of the spine. That's the picture to the left. So the screws are placed to the right to that middle spinous process. And when you do that, you only have to expose the muscle to that point where the screws go in. The next picture over, you'll see how far out laterally the screws are placed. You have to expose the muscle tissue off the spine all the way out to that point, sometimes even out to the tips of those little processes laterally. We call those the transverse processes. That's very debilitating to a patient if you have to remove the muscle tissue all the way out to the lateral portion of the spine. So it makes a big difference in blood loss. It makes a big difference in time of surgery. The stability is actually better if the midline screws are placed appropriately. The strength is about 30 to 37% stronger in rotation than you'll get with a traditional pedicle screw, meaning you feel better. You feel stable, and you feel like you can get back to life quicker as you heal up. And most of our cases that we do now are with this traditional midline screw. So when patients talk to me, I kind of go over that on each case Some patients, especially if they've had previous surgery, they've had their instrumentation placed, we have to use the old traditional type of screws for them. But if they haven't, especially haven't had surgery, we can do some of the newer type instrumentation. This next picture is a picture of a cervical spine fusion. This is called an inset plate, or what we like to call a microplate. It's a very small plate that goes over the front of the spine to lock that little spacer in between the bones and to allow it to fuse. So this can be placed very minimally invasive. I can do this in the cervical spine through a 1-inch incision in most cases. Usually takes about 30 minutes to place. So obviously that can be done for most people on an outpatient basis. Another big change, we used to have to take your bone graft from your pelvis. So we'd have to make a separate incision, take bone graft from your pelvis, and then place it around your spine to get the spine to heal. Nowadays, we've come up with different types of biologics that allow us to get your spine to fuse without harvesting it from you. Obviously, if we don't have to take it from you, that gets rid of that pain associated with that. A lot of patients had chronic pain just because we took a bone graft from them. They may have healed up from where they had their pain initially, and now they had a new pain that they never had before, and that obviously can be very frustrating for someone. Well, we've gotten rid of the need for that now with some of the newer types of bone grafts that we can get off the shelf without taking from you. You can see some of these, we add a little bit of your blood potentially to it, and it serves as an artificial bone graft that we can place in pretty much any void, whether it's around your spine or between the bones in your spine, to allow them to grow together and heal. That's a picture you can see of one of our types of sponge bone graft that we use commonly. Another big problem that we see is disc herniations. That's where part of the disc material has come completely out of place, and it's starting to compress the nerves. What most patients feel with that is just leg or arm pain. They have extreme pain throughout those areas. They get numbness and tingling, maybe even perceived weakness down into the extremity. The picture you're about to see is a great representation of what a disc herniation looks like. A disc in general is made of a hard outer surface, and it's made of a very sponge-like inner portion. If that inner portion, called the nucleus, comes out of place, like you can see in this picture, the nucleus is that purple material, looks like a purple goo, that's come out of position, and now it's pushing directly up against that yellow nerve. Well, that's not exactly the colors we see surgically, but that's a great representation of what is happening. And obviously that nerve is not very happy about that, and would give the patient a lot of symptoms. When we see that, we still try to treat people conservatively for it. Obviously, it may end up requiring surgery to take that pressure off the nerve. It may not. The next picture you're going to see is an MRI. On the MRI, you'll see on the left side of the screen a large mass that's compressive. That is the herniation itself. And again, you see the blue arrow that points at it and says herniated disc. That large bump in the middle there is the disc material. The thecal sac represents the nerves that are being compressed. So what will we do? Well, we'll see you, we'll examine you. We have the suspicion maybe that you have a herniation. We may send you to physical therapy or send you to have an MRI. Once we see this problem with the MRI, as long as you don't have any obvious neurologic deficits, we may send you for an epidural. If you do great, we don't have to take you to surgery. Obviously, if you continue to have problems, we're going to be looking at surgical fixation for you. Most of the time, that's called a microdiscectomy, or what we'll call a laminotomy discectomy, meaning that we're taking a very small portion of the bone away to get access to that nerve and to remove the disc that's come out of place. That typically can be done through a 1-inch incision. In this picture, you can see we're using a microscope. Since we're utilizing a very small incision, we're really dissecting very minimal muscle tissue. The procedure takes somewhere around 30 to 40 minutes to take the pressure off the nerve. It's an outpatient procedure. Typically takes about a month to fully recover from the procedure, where you can return to all activities. The The next picture is going to show you an example of the small tubular retractors that we use. A lot of times we're able to place this down around the spine without having to cut any muscle at all. We're simply dilating that muscle tissue to gain access to where the nerve is pinched. And from there we can do the procedure around the bone and the nerve very easily. The last picture again shows an example of us moving the nerve out of the way to retrieve the portion of the disc that's compressing that nerve. So this is your typical, what people think of as a microdiscectomy, or again a laminotomy discectomy. These procedures cannot be performed with laser. A lot of patients ask me, is this a laser procedure? For the most part, that is a misnomer that there's any real benefit of laser spine surgery. When we do these procedures, again, some of the bigger procedures we do in the spine, sometimes they require a stabilization procedure, meaning they require a fusion. A lot of patients nowadays are looking for more types of motion preservation. Obviously, if you had a bad knee or a bad hip, we're usually not fusing those areas. We're usually trying to do a replacement where you continue to have motion. But in the spine, a lot of times we're taking that motion away. There are ways to try to fix your problem in your spine, whether it's your neck or your back, and to keep your motion. That's called a disc replacement. They're commonly done for the cervical spine today. They're less commonly done for the lumbar spine. The main reason for that is there are a lot of vascular challenges in the lower lumbar spine that have complicated these procedures. Been a lot of litigation in that regard. So most of the time these procedures, especially in our market, are done on the cervical spine. This is an example. The picture you're seeing is a cervical fusion. That portion of the spine, spacers have been placed between the bones. The bone has grown through. There's a plate on the front of the spine. That portion of the spine is fused. It does not move at all anymore. Well, obviously removing several segments of the spine decreases your motion significantly, and that can be a big problem for you as well. It can affect the adjacent segments above and below, leading to more problems with those areas over time. So the next picture you're going to see is what we call a cervical disc replacement. If you see it there, you see that it has a ball and a socket. Just like your hip joint, it moves. So when you move your head, that implant will flex. When you extend your head back, that implant will extend, so you can continue to have motion at that level. And the next couple pictures are just going to show you that implant placed into the spine, flexing and extending. This device has become much, much less invasive over time. It no longer has the little screws over the front of the spine, and it's secured completely inside the disc space by itself, more like the implant that you're about to see. So most of the more modern disc replacements, whether it's cervical or lumbar, look like this. There are no screws. They're really held inside that disc space. They grow into the tissue, and then they become part of your body. Some people will ask, well, can they fail over time? Is there ways they can fail? They can. Your body over time, if you developed an infection around them, they could become loose, and then you still require a fusion procedure to go in and stabilize that segment. So some people will think, well, I'd rather just have a fusion. I have the surgery once, it's done, but you got to remember you do lose some motion with each level that you have fused. One of the last areas we commonly see is Sacroiliac Disease. That's the joint that connects your pelvis, your sacrum, and your ilium together. It's a very immobile joint, but it does cause a lot of disability for patients, giving you a lot of pelvic pain. Men less commonly than women. Women can get some trauma to that joint from vaginal birth during pregnancy, whereas men obviously don't get that. How do we treat it? We treat it the typical way that we do any other orthopedic issue. We treat it with medications. We treat it with physical therapy. We treat it with shots around and into that joint. Occasionally we can perform surgical procedures where we fuse the sacroiliac joint. The next picture is going to show small bars that go across that joint to grow the bone together in the joint to heal it permanently. That has over time had increased success, but I would say that the success rate is not optimal. Therefore, we don't typically choose to perform that surgery or refer patients for that surgical procedure unless there really are no other options through our pain management department to treat it. One of the newest and most exciting procedures that I do is called an in-office kyphoplasty procedure. And what that procedure is for patients that have spinal fractures, what we call compression fractures. Typically, we would have to take you to the hospital, put you to sleep under a general anesthesia. The procedure would probably take 30 to 40 minutes to perform, simply because of all the setup and use of the surgical staff there. And then you'd have to heal up, and you'd have to heal from the surgical anesthesia too, which can have a lot of cognitive issues for the elderly. Nowadays, we're able to do the same procedure in our office. It takes about 20 minutes to perform, so less time to actually do the procedure. And there's, other than some 1% lidocaine, like you would get if you went to the dental, to your dentist for a procedure, there's really not any other anesthesia that's used. And it's extremely tolerated. I probably perform anywhere between 50 and 80 of these procedures a year in my office, and I've been doing that for about 6 years now. So we're probably up to about 300 or 400 of these procedures without any issues. So this is an example of a compression fracture. You see how the bone is wedged and broken. With the kyphoplasty procedure, we're numbing your skin, we're numbing your muscle. We're placing a very small needle through the bone into the portion of the vertebrae that's compressed. We're placing a small balloon into that area and then slowly attempting to lift the bone back up. After we have the bone lifted back up, we're injecting a bone cement inside the bone to act as an internal cast. And what that does is it stabilizes the fracture immediately. Obviously, if you had a broken arm, we'd put a cast on your arm, but we can't do that as effectively with a spinal fracture, so we have to put the cast inside the bone to help stabilize it. When we do it obviously live with one of these x-ray machines. We're not trying to guess where we're putting the material. This is done at all times utilizing an x-ray technician to isolate the bone, and then me as a surgeon to perform the procedure. If you want to see that in more detail, you can go to YouTube and look up McFarland Kyphoplasty, and you can actually see a video of me performing that in our office on one of our patients. And that is the end of our lecture tonight. Obviously, let's see, do we have any questions I have to answer? Let's see. So I see a couple replies. Not a lot of questions tonight. Question, how do I get started to find out if I'm a candidate for regenerative medicine or if I need surgery? A typical appointment with me. You know, the first thing is we need to sit down, we need to look at where your problem area is, we need to talk about whether this is something that could be performed. Now, if you've already been seen in our office, let's say you've had x-rays, you've had MRIs, and you want me to look at your information to see if you're a candidate for stem cells or regenerative medicine, all you have to do is call in and ask. I'd be glad to look at your information and your imaging studies for you at no cost to see if that's something that may be appropriate to help you with your pain. Next question, are outpatient procedures performed in a hospital? Majority of outpatient procedures nowadays are performed in ancillary surgical centers. We have a new surgical center, Coastal Virginia Surgical Center, where the majority of our outpatient procedures are going to be performed. Currently, we are performing those procedures at Mary Immaculate Hospital in their outpatient surgical pavilion. Another question I got was, will there be any pain after a kyphoplasty? The kyphoplasty is an interesting procedure. Once you put that bone cement into the bone that's fractured, literally 50 to 75% of the pain is gone immediately. The cement hardens, and by the time you get off the table, the bone is stabilized by that internal cast. You may have a little bit of soreness over the next couple weeks as the bone heals, or if you get any little bit of bleeding around the tissue where the needle went into the skin. But typically after a few weeks, the bone is pretty well healed back, and your pain is pretty well resolved from that fracture. Had a question from Deb Martin about, can stem cells help with a medial meniscus tear in the knee? That's a great question. I've treated several medial meniscus tears in the knee with very, very good results, and it all depends on where the tear is. If the tear is in a location where there's a fairly good blood supply, the stem cells can work very well, especially if the meniscal tear is small. If the meniscal tear is very large, or if it's extruded out into the joint, I mean it's a large tear that's flapping in and out of the joint, that's going to have to be removed. So a lot of times it's reviewing the MRI to see. Most recently I used it on my wife. She injured her knee running. She had a medial meniscus tear. We thought she was going to have surgery again. She's had 4 previous. I was able to do a stem cell injection on her and completely resolve all of her symptoms with it, and she's healed up greatly. But I've used it on countless number of patients with medial or lateral meniscus tears to treat that. And I think that might be the end. So, I'd like to thank everyone for joining us tonight. This was kind of a novel approach for us. This is our first time that we've performed a lecture in this way. Part of it's because of what we're going through nationally with our healthcare crisis. We want to do our part here at the Orthopedic and Spine Center and try to protect our patients and to keep you safe and keep you away from us and other people that may be contagious to you. This may be the wave of the future, where we're doing some lectures like this, especially in the spring or fall, to try to decrease the number of warm bodies gathered together in a room discussing these types of topics. So there may have been a few glitches, and we'll try to get those worked out over time with future lectures that we give here. But we really appreciate those of you that showed up to hear me talk tonight. If you have any other questions, any other concerns, you let me know. If you're interested in being screened for regenerative medicine and stem cells, or make an appointment, you can message us on Facebook with your contact information, or you can call our office directly at 757-596-1900 and make an appointment with me, and I'll be glad to see you anytime. Thank you.